So, three, two, one. Over to you, sir. You can start the session.
Good evening, ladies and gentlemen, and a very warm welcome to this evening's webinar. I am Vijay Chopra from Heart Failure Association of India, and this is in continuation with our education programs. We are starting monthly webinars for our cardiologists, and for the first topic, we have chosen peripartum cardiomyopathy. It's my distinct pleasure to welcome Dr. Karen Sliwa, who's an acknowledged world leader in this field, and she's joined by Dr. Justin Paul, who has the largest series of these patients in our country and possibly in the world from a single center, and Dr. Shantanu, who's going to show us some echo, and Dr. Muthu Prabha, who's a gynecologist. So a very warm welcome, and we look forward to a fruitful interaction. Do send your questions in live so that they can be answered. So Justin, over to you to take over the proceedings.
So thank you so much. Thank you, Heart Failure Association, for this opportunity to share the burden I have for this pregnant women with the heart disease in India. So to start with, my aim is to, for those of the obstetricians and the cardiologists who are logged in today, my desire is that you always work together in tandem to take care of this pregnant women with the heart disease so that the attributable mortality related to pregnancy and heart disease is taken care of well in whichever part of this country and the world you are in. India is a country, as you know, is shooting up its population. Now we are into 1.4 billion, and thankfully the fertility rate has come down to 2.2, and then it's come below 2.1. It's almost like the population starts going down. Now, this is the number of mothers who are dying of pregnancy per year. We started with almost 500,000 mothers dying during pregnancy in the world. And now the number has come down to some extent. Now let us see what is happening in India. We started with almost 100,000 mothers dying in 2000, and now we have almost 35,000 mothers dying during pregnancy every year. So if you look at the world statistics, we are the number 2 in terms of the number of mothers dying per year. So this is about this country. Now, this is where we stand. We have significantly reduced our maternal mortality. Just to show what is happening in China, another country which has almost an equal population to us. There, about 5,000 mothers are dying per year, whereas in our country, about 35,000 mothers are dying per year. So what do we do to bring this down from 35,000 to 5,000 or less? So something important that we all need to look into. So this is just to show you some other example. So what is really happening to maternal mortality rate? What we earlier saw was the number of mothers dying actually. This is the MMR, that is the number of mothers dying per 100,000 live births. So this is the maternal mortality rate in India, which has come down significantly compared to 2004. But if you look at some other states, this is the state where I am in, Tamil Nadu. We have done a good job, and this is the state Assam. This is one of the states with the highest maternal mortality, followed by Uttar Pradesh, and we also have Kerala, where Dr. Hari Krishnan is. So Tamil Nadu and Kerala have a very good achievement in this area. Now coming to the Tamil Nadu, what we could really glean out of it is we have a decent way of attributing cardiac deaths here, and we find that there are almost 500 to 800 mothers dying per year, of which about 10% is due to heart disease. So there is a paradigm shift in the maternal mortality. If you look at on the left, what has happened is now shifting to what is going on in the US and UK, where the largest chunk of maternal mortality is contributed by cardiovascular disease. And that is where we as cardiologists come into the picture to see what we can do to bring this down. So the reason behind is the significant improvement in obstetric care, where the bleeding part of it is taken care of, the infection part of it is taken care of, hypertension is taken care of very well. Cardiologists and the obstetricians have done a great job, and cardiologists have done a great job of taking care of the complex congenital heart disease and valvular heart diseases, that these children, instead of dying young, they come up to the childbearing age, and we have more and more people with the corrected heart diseases coming to pregnancy. Society at large, the age of marriage has increased significantly, and the lifestyle has changed. Obesity, diabetes, all these things are coming in. So the mothers are coming in complex heart-related issues. So what are the other burdens that we also need to look into? The burden, the patient's fear. In a country like India, what happens when a patient realizes that she has a heart disease in pregnancy? Whether I'll be able to live, whether my baby will live, whether my husband will keep me, my mother-in-law will drive me, and all these things, it is going to happen. And in fact, a lot of marital conflicts have happened and domestic violence. The early part of our registry, we did a very small sample survey. About 17 women at the prosthetic well, first 17 women. My assistant evaluated for this domestic violence. Every single person had some kind of domestic violence. We are investigating it into a larger extent, but the sad part of it is these women suffer a lot. So what is the doctor's burden? Often we find that the cardiologists and the gynecologists or obstetricians are not really working always together. So the cardiologist looks at you do this and moves away. The gynecologist says that why don't you have it in the cardiac ICU? The patient has failure. So who takes care of the mortality? Who becomes responsible for it? Nowadays, as maternal mortality is being significantly audited. So it is a big issue that unless we are working in tandem and understanding each other's responsibility, unless we work as a pregnancy and heart team, where it is formed predominantly by the cardiologist and the obstetrician, joins and supported nicely by the pediatrician or anesthetist. My request and desire is that every single person who is here in your institution, if you don't have a pregnancy and heart team, please do make one. Now, this is the maternal mortality rate in Tamil Nadu. And as you can see, at this point of time, we started the MMC pregnancy and heart disease registry, where we were losing about 71 mothers. Earlier, if you look at that, most of the heart diseases were not really attributed to, maternal deaths due to heart diseases were not really attributed to heart disease. The evaluation and the screening system were not very appropriate. Now we have made it very appropriate now. So this is the time we have started the Tamil Nadu Pregnancy and Heart Disease Registry in January 2020, 1st of January 2020. And we have enrolled as of now 1,300 patients. And MMC Pregnancy and Heart Disease Registry, we have stopped. We have enrolled about 1,031 patients. Now I looked at what is really happening in India because Hari had given me a topic of the burden in India, which I had not done earlier. So the last 24 hours, I sat and collected, gleaned some of the information that I could get from various parts of the country. Now these are the the number of studies that I could handle from India were about 20 to 25. 25 studies, of which about 4 I had to ignore. From the state of Maharashtra, these are the 4 centers. The one in green are prospective studies and one in pink are retrospective studies. And you can see the number of patients enrolled here. And this is from the state of Karnataka. And these numbers are from the state of Punjab. Punjab has, from PGI, we have large retrospective study, and from Ludhiana also we have large retrospective studies. And in Delhi, from 2 studies from AIMS and 1 from VMMC, we have quite a large number, but again, they are retrospective studies. This is from Jammu and Kashmir. We have some data. The data where there is orange mark, or that means that the paper does not clearly specify what exactly the type of study was or how the data was collected or where the data was missing. And this is from the state of Hyderabad and Telangana. And these are the numbers that we have at this point of time. And from Nainital, and from Jharkhand, Kolkata, and Shillong. And this is from Tamil Nadu. So putting together, we have about 2,500 patients, and now we have started and collected the data in Chennai, where we have 1,031 patients. As you can see, the incidence of heart disease also mentioned by the sites. Now, I did a meta-analysis and collected some of the data. As you can see, if you look at the prospective studies and the retrospective studies and putting them together, totally almost we had 4,100 patients, of which 2,800 were a part of retrospective study and 1,200 were a part of various prospective studies. And as you can see, the rheumatic heart diseases form the biggest chunk, whether it is a prospective or retrospective, they form almost 70% of the heart disease burden in our country. And the congenital heart diseases, they form about 20% of our burden. And cardiomyopathies constitute, according to the guidelines used, the definitions used, they vary widely. And this is the incidence or the type of deliveries. Some of the smaller studies had a very high incidence of cesarean section in these mothers, going up to 35 and 45 degree. But however, the larger studies ironed out the numbers and they brought it down to 25. This is how the data is. And as you can see, the mortality has been in the range of about 2.5 to 3 across the various centers. And the heart failure ranges have been around 7 to 10% of the mothers develop heart failure during pregnancy. This is from 2,600 patients which had this kind of data. And when I look at the tier 1, tier 2, and tier 3 cities, the number of patients are given in the brackets below. You find that the tier 1 cities, the cesarean rates were high and the mortality rates were low. So when I calculated them according to this metropolitan, urban, semi-urban, and rural areas, sadly, we have only one study from a semi-urban area and one study from a rural area. There are a large number of studies in the metropolitan and the urban societies. As you can see, the mortality is lowest in the metropolitan societies. So if we really want to target the maternal mortality related to heart diseases, we also need to concentrate much more on the urban and the rural areas where the mortality related to the pregnancy and heart disease is quite high, and also the heart failure related to pregnancy and heart disease is quite high. So this is our data. I'm not really giving out all the data as of now. Out of 1,031 patients, again, as you find, almost 45%, 47% of them had significantly rheumatic heart disease. And the next largest group was atrial septal defects, almost 193 patients with atrial septal defects, and 57 patients with ventricular septal defect. So one of the biggest difficulties that we had is in terms of collecting the data, because most of the hospitals right now that are dealing with the pregnant women with the heart diseases have no particular system to go on into the finer cardiac details. They have online data system entry where you can say the heart disease or not, but then what kind of heart disease and what is the kind of follow-up. It was quite difficult, but we were able to get through because of the dedicated support of many assistant professors and postgraduates here. So this was our outcome. As you find that almost 82 patients had heart failure, and there are a number of patients who died of prosthetic valve thrombosis was 11. So this prosthetic valve thrombosis is another area of prosthetic valve management in pregnancy is something that I really want to concentrate for a country like India if we really want to reduce the maternal mortality. Because as of now, we don't have very clear-cut guidelines. Even the ESA guidelines that we have, many of them are based on opinions and single-center data. We don't really have a comparison data of what we can do in the first trimester. What should we do between the 6 to 12 weeks? Do we have any comparison data? We don't have. Do we have any comparison data between in the last how to change over towards the pregnancy time? We don't have. We have data from some of the centers based on which we are working on that. And how do we titrate the PT and INR? How often you can do the PT and INR in a larger country like India? This is another big limitation in managing this prosthetic valve women. In fact, of these 11 prosthetic valve deaths, I myself would have handled about 7 or 8 prosthetic valve patients. So it is very important that we take a very great stress in managing prosthetic valve patients in pregnancy. And in fact, the government should make antenatal mothers with the prosthetic valve, the metallic prosthetic valve, a notifiable disease. So thank you. So my prime stress is that this pregnancy and heart disease team concept is extremely important, and obstetricians and cardiologists have to go hand in hand to help these women. These women are already going through a very tough time in their families and their society. At this point of time, with the cardiologists and the obstetricians in the OPD are very crowded, and towards the end of the day, after seeing the 150 patients, this 151 patient come with all these difficulties, still we really need to work hard. So data is as of now sufficient, not sufficient to formulate guidelines to improve the care. We can give position statements, but in fact, ESC in 2018 has called for starting registries. Based on that call, we started the Tamil Nadu Pregnancy and Heart Disease Registry. We have as of now enrolled 1,350 patients. And after publishing the MMC Pregnancy and Heart Disease Registry, we'll be looking for a national pregnancy and heart disease registry across India. And any of you are willing to collaborate, please feel free to contact. And the data from the rural and the semi-urban areas are extremely important in fine-tuning our target towards next decade. Thank you very much for your patient listening. Hope I finished in time.
Yes, Paul, you can invite the next speaker. Paul, you are in charge. Call the next speaker. Dr. Muthu Prabha, probably?
Yes, sir. And shall I start, sir?
Yes, please.
Good evening, all. At the outset, I would like to thank the organizers of HFAI who have given me an opportunity to share this platform. Can I have a slide share, screen share, please?
Yes, ma'am. Hello, ma'am.
Yes, sir.
Ma'am, your screen is not visible.
Yeah. Sir, is it visible, sir? Scenario one.
Yes.
Yeah. So having now heard about the quantity of the burden of heart disease, I think we now will move on to the quality of the burden we as obstetricians are facing, sir. So I thought I'll share 2 or 3 scenarios which we are facing on day-to-day practice. And this scenario, I'm sharing it on a chronological basis. That is, the first scenario is the one which we came across in 2010 when I was on duty, a primary gravida breach in labor, a case of severe mitral stenosis with moderate pulmonary hypertension who was having her checkup elsewhere. And because of financial constraint, when cesarean section was planned, she wanted to come to a government setup. And as she came in labor, we took up for an emergency LSCS under spinal anesthesia. On table, she went in for arrest. She was revived, intubated, and put on ventilator. She was extubated after 4 hours, again went in for arrest after an hour. So this is where we obstetricians are standing. Though the problem was on the intraoperative table, it was the obstetrician who had to face the scenario and the attenders. This is one problem which we faced in 2010. The second scenario was in 2011. She was a para 2, live 2, who had normal vaginal delivery at PHC. She had her first delivery at mother's home, which went uneventful, but she was diagnosed as heart disease earlier itself. So she took medications for heart disease, went on smoothly in the first pregnancy. The second delivery was at her in-laws' place, as Dr. Justin rightly pointed out that there is a constraint when they come to the in-laws. So she did not reveal that she was having heart disease. She went to the PHC, had a regular checkup. She delivered. She was discharged after 48 hours. But on the third day, she developed breathlessness, for which she went to the same primary health center. She was treated with bronchodilators. On the fourth day also, she had the same complaint, went there. And on 6th PND, she was referred to a medical college with features of heart failure. The problem here is the mother has been taking medications without the knowledge of the in-laws, and she has been collecting her medications from a government hospital with a record without she coming in person. This is one of the stigma we are having with the heart disease, and they don't reveal the heart disease. And when in medical college we examined, we are able to locate a thoracotomy scar, and on probing we came to know that she was a known case of heart disease. She was on medications, but she never revealed it to the medical officer of PHC or to her in-laws. This is the second scenario, which was in 2011. The third scenario was in 2012. A third gravida, para 2, live 2, admitted at Medical College Hospital. This is the current scenario that is in 2020. This is where we are standing. Previous to normal vaginal deliveries, I think, Justin, you remember that we had a discussion with you regarding this case, no?
Yeah, yeah.
Her echo findings revealed bicuspid aortic valve, mild AS, severe AR, moderate MR, PDA with bidirectional shunt, and global hypokinesia with left ventricular systolic dysfunction and ejection fraction of 47. This is where we are standing in 2020 in spite of so many things we are discussing with the obstetrician, the cardiologist, the multidisciplinary approach. One who should not have faced a third gravida, no? She should not come as a third gravida in 2020. It was the obstetrician's responsibility to have terminated her in the second pregnancy itself, that is undergone contraceptive measures or permanent method of sterilization. Then we had another scenario that was 36-year-old para 4 live 4, which I have not shared on the screen. I thought if there is no time, it will not be possible for me to share. So I'll just tell you the history. A 36-year-old para 4 live 4 closed mitral commissurotomy done at 18 years of age. She was advised MTP at 8 weeks of gestational age. She was an unbooked and unhumanized case. First time when she came for visit at 8 weeks, they advised MTP, but she never turned back. And she was admitted 2 days prior to her EDT at Medical College Hospital with severe mitral stenosis, pulmonary arterial hypertension, mitral regurgitation, tricuspid regurgitation, and atrial fibrillation. And we lost this mother also. Then another one was a 34-year-old, gravida 3, para 2, live 2, previous 2 normal deliveries. She was diagnosed as rheumatic heart disease since 15 years of age, mild mitral stenosis, moderate MR, severe AR. She discontinued her drugs on her own for the past 1 year. She was admitted at 32 weeks of gestational age with hemoglobin of 5.5 grams. This mother was also advised MTP in the first trimester in a private hospital. Once MTP was advised, she never turned up for ANC in that hospital, but landed up in Medical College Hospital at 32 weeks of gestational age with a hemoglobin of 5.5 grams. This is the place where we as obstetricians are standing. So I think, as Justin rightly pointed out, when coming to pregnancy and heart disease, where do we stand? I think that we are standing in a dark tunnel, hoping and waiting to see some light at the end of the tunnel, no? I think it is mainly because of, as Justin rightly pointed out, lack of evidence-based guidelines. And this is the need of the hour for starting a national PhD registry. As Justin pointed out, we are already having a Tamil Nadu PhD, that is Pregnancy and Heart Disease Registry, where we have already enrolled a large number of patients. But still, I think it would be better if we go in for a national PhD registry so that we can generate our own data and develop our own evidence-based guidelines. And I think we need a well-coordinated team of primary, secondary, and tertiary level caregivers so that in all the scenarios, you can see that one, either it is missed in the primary healthcare center or in the secondary level or in the tertiary level. All the three are at fault. In the primary care level, they have to screen in the early registration itself for any heart disease. In the secondary care level, the proper timing, mode of delivery, and place of delivery has to be planned. And the tertiary care level, once they are delivered, it is the duty of the obstetrician or the team who is taking care of her to see that she's getting an ideal contraceptive. If at all she becomes pregnant, to go for an early MTP at the first trimester. And the next one is we have to start the screening right from birth. That is DEIC, that is a district early intervention center, then go for RBSK, then go for RKSK. And it's the right time we trace the young girls from the adolescent age group so that once heart disease is traced, we have to go for a pre-pregnancy counseling regarding the pros and cons of becoming pregnant and whatever is the chance of congenital heart disease. Everything has to be discussed in the pre-pregnancy counseling itself. And even in early registration, a thorough clinical examination should be advised. As I said, they have missed a thoracotomy scar. If only they have gone in for a thorough clinical examination, they could have gone in for the thoracotomy scar, they could have examined the cardiovascular system. And now there is a great role for screening echo. As I told, after this Tamil Nadu Pregnancy and Heart Disease Registry has been started, we have got many number of heart disease cases. And the data which I'll share in the coming slides. Then there should be a risk assessment approach and a multidisciplinary approach, as Justin rightly pointed out, with multidisciplinary team consisting of the obstetrician, the cardiologist, and anesthetist is all the more important. As I said, in the first case, it was the duty of the anesthetist to see that she doesn't go for an intraoperative cardiac arrest. Then a plan regarding the timing, mode, and place of delivery has to be described in detail in the first trimester itself, so that nearing term they need not have a dilemma to go to which place for delivery. Then regarding contraception, it is the duty of each obstetrician who is delivering the mother to tell her about the spacing and go for a permanent or temporary method of contraception. If at all there is a contraceptive failure, the role of MTP in the first trimester has to be emphasized. Then there was a study conducted in TVMCH from the period of June 2015 to July 2016, and we had about 7,830 deliveries, of which 102 were heart disease complicating pregnancy. Of these, 5 cases were delivered outside and referred to TVMCH. The other cases were delivered at our center. Out of this 107 cases, we had 7 maternal deaths, the incidence of heart disease being 1.25%. And in that, rheumatic turned out to be 53, congenital heart disease was 35, peripartum cardiomyopathy was 5, and others came to under 14. Justin, with your permission, I would just want to compare what was the incidence in 2016 and the incidence in 2020. I will not project the slide or the figures. I'll just tell the figures. No, for the past 5 months, I just made a study in 2020. That is from August 2020 till from April 2020 till August 2020. We had total deliveries of 3,800, of which heart disease we had 175. We have not enrolled everything in the heart disease registry, because why I am telling this is because after we insisted on routine screening echo for the antenatal mothers, we were able to pick up trivial MR, physiological TR, MVP, everything was brought under heart disease, and all the periphery people, that is the primary and secondary care centers, referred them to us, so that we are having almost 175 cases in a period of 5 months. That is the importance of this Tamil Nadu pregnancy and heart disease registry, and that's why I am telling, if we go for a national pregnancy and heart disease registry, we could bring about more cases so that we can give proper AN care. To complete, there is a saying that a pregnant woman is like a ship on a stormy sea, and a good pilot in charge must guide her with prudence if she is to avoid a shipwreck. Here I will put it as a good pilot. Instead of pilot, I will put it as a good crew, and the crew should consist of the obstetrician, the cardiologist, the pediatrician, and the anesthetist. Together, the crew should be formed so that we shall guide her and we shall avoid a shipwreck for the pregnant mothers. Thank you for the patient hearing.
Thank you, Dr. Muthuprabha. It was a very wonderful ride across the sea with you being the pilot. So you took us through.
No. I am not the pilot. No, as I said, we have to be a crew.
Now, I should thank the Heart Failure Association of India and Dr. Hari Krishnan for bringing us an international authority in this area, Dr. Karen. Dr. Karen is a very gentle and soft-spoken, but very knowledgeable person with a lot of presentations. In fact, she has been a role model to women cardiologists across the world, and she had been featured in the European Heart Journal as a model cardiologist. So in fact, thanks to Hari, I had an half-an-hour discussion with Karen. She was so helpful in guiding us through our MMC Heart Disease Registry. Karen, it is a pleasure to welcome you, and the podium is yours. Thank you so much for joining us.
Thank you very much for the very kind introduction. And it's really a pleasure giving this lecture today. Can you see my screen?
Yeah.
Yes, okay. I just want to open it. Okay. So I thought I give a lecture based on a publication which came actually out on Saturday. So this is a publication. It was published in the European Heart Journal, as I said, just on Saturday. And it's a clinical presentation, management and outcome of women with peripartum cardiomyopathy, and basically the data of the EOC-EORP registry. And obviously, I will discuss the diagnosis or management embedded within the paper. So peripartum cardiomyopathy, just for some of the listeners, is an idiopathic form of a cardiomyopathy. It presents with heart failure towards the end of pregnancy or the months following delivery, when no other causes of heart failure are found. It's a diagnosis of exclusion. In the left ventricular ejection fraction is usually below 45%. And there are a number of position papers by the ESC working group on peripartum cardiomyopathy. The first one is in 2010, where this definition was basically created or updated. And then there is an updated position paper on the pathophysiology, which was published actually last year. So how did we started to have a global registry on peripartum cardiomyopathy? I just want to spend a second on it because I can see all your efforts creating local data for India, and you are such a large country, you really need your local data. So it takes time and it takes effort and it's not easy. So we initiated a working group on PPCM in May 2009. Then, as I mentioned, we published the first position paper and identified the gaps, which was then basically the basis to plan the global registry, which was initiated in 2012. And I want to highlight that the investigators and the participant sites were not funded. We had no funding for that. So it's really based on voluntary contribution to allow that we can share knowledge about this important disease. But we had some support from the Heart Failure Association for the web-based data collection, monitoring assessment, and some other aspect. So while we were creating our database and collecting data, we also published position papers by this working group on the long-term prognosis, subsequent pregnancy, and overall management of peripartum cardiomyopathy, which was in 2018. And other position papers. So coming now to the study. So we wanted to describe the clinical presentation, management, and 6 months outcome in patients with PPCM globally. And between 2012 and 2018, women with newly diagnosed peripartum cardiomyopathy were enrolled into this program. We published then the study design, patient selection, and the way of data collection in 2014. And our inclusion criteria were peripartum state, the signs and symptoms, you need to have an ejection fraction less than 45%, and other causes of heart failure needed to be excluded. It was an observational study with no specific protocols or recommendations. So we basically wanted to capture what the physicians are doing in the different parts of the world. The regions were defined as Europe, Africa, Asia Pacific, and Middle East, which is based on the WHO definition, and ethnicity was self-reported. We collected then core data, such as the ECG, information on neonates, because we want to validate that the patient really existed and the data entry was accurate. So here you can see the participating sites. I mean, you can see we highlighted Europe, but we had centers from really many regions of the world. So we were 739 cases from 43 countries where we had Europe, Africa, Asia Pacific, and Middle East. And ethnicity was Caucasian 33, African Black 28, Asian 21, Middle Eastern 13, and then we had some others. So there were many contributing investigators, and we're really thankful to every single one of them. I highlighted the contributors from India, so you can see the names listed here below. And there are many others. So what did we find? So in the age, you can see that the mean age was 30.7. And Africa was slightly younger, but otherwise it was fairly similar. Comorbidities, you saw differences like diabetes was higher in the Middle Eastern patients. Then smoking was most commonly in Europe. In Africa, we had also had patients with concomitant HIV disease. Hypertension pregnancy was particularly high in Asia Pacific, followed by Africa, but also Europe, roughly 1/3 of the patient. Preeclampsia and the current pregnancy, you can see Asia Pacific 48%, otherwise roughly 25%. There are a few women who develop PPCM after having a stillbirth, but most commonly women who had more than 2 children. And then you can see that atrial fibrillation or flutter, we had only in 2.3% of the cases. Most had sinus rhythm, and the heart rate, as expected with acute heart failure, was elevated. So women from the Middle East had the higher prevalence of diabetes and multiparity, which was significant. And there was a marked difference in concomitant preeclampsia and hypertension, and what I have just mentioned before. So continuing the baseline characteristics, we were surprised to see that the left ventricular ejection fraction was fairly similar across the regions. So all the women presented roughly with an ejection fraction of 30. But if you'll be breaking down the numbers, you can see that 31% had an ejection fraction less than 25%, which is particularly poor. Then roughly a third, 25 to 35, and more than 36, again, a third. Then if you're looking at the left ventricular dimensions, there was also the left ventricular end-diastolic diameter was dilated. Also the systolic function, as expected, was dilated in most of the patients. So there was no interregional difference in LV ejection fraction, but women from the Middle East had a higher end systolic and end diastolic diameter, so they had more dilated hearts. This is actually an important slide. So if you see, these are the women when they present function class 1 to 2, 3, and 4, and the percentages. And it is important to note that there are 20% of the women who had an ejection fraction of less than 25% had actually very minimal symptoms. So symptoms are not very good guidance for very poor systolic function, because the women have a high, they're young, they're fit, they had no comorbidity, they have a high compensatory reserve. So don't be fooled if a patient doesn't look very ill or hasn't got a very, is not very short of breath. It does not mean that the heart function is good. So a cardiac ultrasound is very important. And as you can see here, it's similar to the other function classes. Then, timing of presentations. So globally, the majority of the patients present within 1 month post-delivery, and not really differences across the regions, but you do have women who present earlier than within 1 month before delivery, and you also have patients who present within 2 to 3 months or even beyond. And these are often women who have, actually they had milder symptoms like shortness of breath, feeling tired, but have not been recognized by the health. Neither first the patient didn't think they had a heart problem, the primary healthcare nurses didn't think, and they were not referred. So the time of presentation varied between regions. In Europe and Africa, presentation the first month after delivery was a bit more common than in Asia Pacific and in the Middle East. And there was a marked difference in the frequency of antepartum diagnosis, with 25% in Africa versus the Middle East, where you had more. So how were the patients treated? So it's recommended that patients, everyone who's postpartum, should be on ACE inhibitors and beta blocker. And as you can see, this is the percentages. So most of the patients received an ACE inhibitor. Most of the patients received a beta blocker. There was no really different, not significant differences. Then MRA was highest in Africa. I mean, spironolactone was most commonly prescribed here. If you look at diuretics, most of the patients had a diuretic. What is important, highest percentage actually in Africa. Ivabradine is a heart rate regulator. It's not recommended in pregnancy. It's only recommended if your patient is on optimal dose of beta blocker. And as you can see, it was actually mainly prescribed in Europe and not in other parts of the world. Digoxin, most common in Africa, is a cheap medication. So it's commonly prescribed in Africa. Bromocriptine is a medication which is now in the ESC guidelines of heart disease and pregnancy as a 2B indication for patients with diagnosed peripartum cardiomyopathy. That means it can be considered, in particular in patients with poor cardiac function. And you can see it was roughly 30% of the African patients received bromocriptine, and in totally, if you take the entire group, it's about 15%. But I mean, it has only been added to the ESC cardiac guideline of pregnancy in 2018. So it's many physicians don't know about it, and it's, as I said, it's also it's per choice. Anticoagulant, relatively little prescribed. Aspirin is usually not necessary and therefore given rarely. So what was then the in-hospital and 6 months outcome? Altogether, assist devices were prescribed very rarely, mainly in Europe, like implantable cardiac fibrillator or CIT. Patient with PPSM can die of a sudden death. So that's why we looked at the information who would get treatment for that, but it's rare. So this is the in-hospital death, and this is a 6 months death. So in hospital, it's basically on an admission. You can see that 2.2% of the patient died, mainly due to heart failure, but also 25% of sudden, and stroke was another mode. And then the 6 months, altogether about 6%, heart failure, roughly 40%, sudden, about a third, stroke, and then presumed cardiovascular. There's no particular differences between the different region. Yeah. So looking now at rehospitalization, who had to come back within 6 months, it was 10% of the patient need to be rehospitalized due to either heart failure or other cardiac event. Looking now what happened to the left ventricular systolic function at 6 months. So recovered, which is an ejection fraction of more than 55, was more than 50, that was the definition, was actually in 43% of the patient. 31% had persistent moderate left ventricular dysfunction, and persistent severe LV dysfunction or death was in 1/3 of the patient. And it was in Europe 17%, 30% in Africa, 20% Asia Pacific, 51% in the Middle East, and there was a difference between the region. So the women from Middle East had a significantly more dilated left ventricles and poor ejection fraction at 6 months, and less than 50% normalized the systolic function within 6 months. So this is new. I mean, not every one of you will be so familiar with peripartum cardiomyopathy, but it was until the study thought it's only common in Africa and not common in other parts of the world. It was in many parts actually never really diagnosed. Then people had assumed it has a particular poor prognosis on the African continent, and our data actually don't support that. So going now a little bit more in depth on the specific outcome of cardiac function per region, you can just see that 6-month change in ejection fraction was, this is altogether plus 15, Europe, Africa, Asia Pacific, and Middle East. So there was a very relatively poor improvement in the systolic function in the Middle East. Mean ejection fraction at 6 months was 39.9 for the patient, and that was different compared to the other regions. And as I again said, the Middle East had the most dilated LV, EDD, and the LVESD. So very briefly to obstetric and neonatal outcome, just over half of the women had a vaginal delivery, and a twin pregnancy occurred at 4%, which is higher than in the normal population. 50% of the neonates had a birth weight below 2,500 grams, and the neonatal deaths occurred in 5% with a significant regional variation. Europe 2%, Africa 5%, Asia Pacific 4%, Middle East 10%. And it is, I think to my knowledge, one of very few studies who are actually looking at neonatal outcome. It's usually not described in women with peripartum cardiomyopathy, and we actually can't really explain why the neonatal death rate is so high. Because most, as you know, most of the women present postpartum, and we don't have a good explanation for it, but I think it's very important to look into that, and that should be part of future research. So in conclusion, peripartum cardiomyopathy is a global disease, but clinical presentation outcome vary per region. 6 months mortality is 5.9%. Over half of the in-hospital deaths were due to heart failure, but at 6 months, fewer than half were due to heart failure and 30% were sudden. All-cause rehospitalization was 10% at 6 months, and less than 50% recovered their LV function. Neonatal deaths occurred in 5%, again, with regional variation. And in the publication is also a take-home figure, which basically summarizes that you shouldn't rely on physical examination, because 42% had no peripheral edema, 41% had no pulmonary rales, so physical examination is not sufficient. Severe LV systolic function, as I mentioned, that 2/3 had an ejection fraction of less than 35%, 2/3 had a function class 3 to 4, but they're patients who have a very poor systolic function and not having a lot of symptoms. 1/3 of the symptoms before birth, 2/3 after birth, and then outcome at 6 months. I did not go into detail about thromboembolism, but it's a very important aspect. 7% have thromboembolism, mortality rate about 6%, readmission 10%, myocardial recovery, and neonatal mortality. So I would like to end my presentation and thank you very much.
So thank you, Karen. That was a very interesting presentation. And in fact, it was good to always hear from the expert. You designed the study and you conducted the study, you published it. And a lot of questions have come, and I understand that you need to leave for the next presentation. So for the sake of getting answers from Karen, before sending it away, we are preponing the Q&A with you, and I thank Dr. Shantanu for agreeing that. And after that, we'll again continue with the webinar. Couple of questions have come across to you. How many of the patients with peripartum cardiomyopathy had the second episode of pregnancy, like pregnancy after an earlier peripartum cardiomyopathy in your data, and how did they fare?
Yes, so we have now a lot of data, and as you know, the first publication only came out 3 days ago. So it is that 12% of the patient had a previous peripartum cardiomyopathy, and we actually have not analyzed if they did worse or if they particularly did worse if they had a very low systolic function. So unfortunately, you have to wait for a future analysis. So I don't have the data for you.
So we had 4 patients, and we lost 1 patient, and those who had a better recovery of LV ejection fraction after the prior peripartum cardiomyopathy, they fared better. We'll come back to you again. And what is your experience on bromocriptine and peripartum cardiomyopathy, and what are your advice on how to use it?
So you might know that I have to declare I'm biased, because I'm the one who developed the concept of giving bromocriptine in peripartum cardiomyopathy. If you Google my name, you see a lot of basic science research, then pilot trials, then larger trials, which led to including it in the European Society of Cardiology guidelines and the South African guidelines. But what I do in practice is that I, like with all medication, I look at the benefits and disadvantages. So if as you know, in South Africa, we also have more of my patients are poor, some live in townships. So if I have a patient who is very ill, so they're in high care, they're have an ejection fraction of less than 20, they're in function class 4, they're on oxygen, I don't recommend breastfeeding. It is actually increasing the cardiac output. And based on the data we collected over 10 years, I would really recommend giving bromocriptine, because in my experience and the clinical trials shows a much better outcome. And you can also look up the German data on that. If I have a patient who is still walking, she's function class 2, her ejection fraction is 38, but she lives in the townships, there is no safe water for the baby, I recommend not to stop the breastfeeding because it might kill the child. And so then I wouldn't prescribe it. So I always balance actually the interests of the mother versus the interests of the child, and including the local circumstances. However, with subsequent pregnancy, we have very compelling data that the outcome is poor if the heart function has not recovered. And we actually give all women who decide to have have another pregnancy and who started with an ejection fraction of less than 40, we highly recommend to give bromocriptine and not to breastfeed.
And is there any anticoagulant protocol that you advocate for these patients who you put on bromocriptine?
Yes, there is actually my German collaborator, they always give anticoagulation with warfarin, but you will see, if you read the paper, you will see that I didn't show the data. The woman who had bromocriptine had no higher rates of thromboembolic events. And we don't give it in South Africa because it's difficult for us with the anticoagulation, the INR. So I'm actually not prescribing it, only perhaps in patients with extreme. Look, I always give anticoagulation if I see smoke in the ventricle, if I see a clot, obviously. But otherwise, I'm not prescribing anticoagulation.
Question, can I ask one question?
Please, please.
Karen, what is if a patient who had a history of previous peripartum cardiomyopathy comes to you, so what is your protocol? Do you look at the ejection fraction, or how will you proceed?
Yes, I mean, it depends. I mean, if it's if the ejection fraction, let's say, is someone who has an ejection fraction of 15 or 20, I see those patients, I really try to encourage them not to plan another pregnancy. If the patient has recovered LV function, we usually recommend that they can go ahead, and I had very good results. So with recovered LV function, they have more children, we give bromocriptine, and I had no one. They usually drop a bit their systolic function, let's say from 50 to 40, but then it gets better again. Then you take also the personal circumstances. So if someone has, let's say, already 5 children, the ejection fraction is now 40. I try to convince them not to try their luck because we don't have data if the ventricle is not get damaged by each pregnancy, what I actually think. And just think, they have to look after the other 4 children. And I tell them, you don't want to leave them behind as orphan if you die in 5 years or 6 years due to heart failure. And I'm very good convincing them not to have more children. So I really go into a personal discussion and take the entire scenario into consideration. And then we usually, but if they go ahead, we obviously see them and accompany them with the obstetricians through the pregnancy.
Karen, one question. If you have somebody on disease-modifying therapies for heart failure and their ejection fraction recovers, how long would you continue? Would you taper them off at some point of time? And the other thing is that if they are on, say, beta blockers, ACE inhibitors, and so on, and ejection fraction has recovered and they want to plan another pregnancy, would you discontinue the drugs for a while to see how things are before advising them?
These are very important questions and there are no good data. So this needs really further studies. What I do personally is that because we can see in the publication there are data on women who actually have recovered their heart function and still can die of a sudden death. And I think it's due to scarring in the conduction system. So I always actually suggest that you continue with a low dose beta blocker because of my very sad experiences with some of the women. I do stop the ACE inhibitor though, if the heart function has recovered. Then I in general recommend not to fall pregnant for 2 years. And then if another pregnancy is planned, as you suggest, you taper down, you have to stop the ACE inhibitor anyway. So you stop the ACE inhibitor, you stop the diuretics, spironolactone, the beta blocker I leave on a low dose because there are also new data that the fetal growth impairment is actually minimal on a beta blocker. So I actually leave them on a beta blocker.
So
Thank you.
some more questions have come in to Dr. Karen. A lot of questions are pouring in. You let us know when you need to leave till such
No,
time.
no, no, I still have time. Yes, no, I can answer questions.
Okay. The thing is, now what has been your experience with the newer drugs for heart failure in case of peripartum cardiomyopathy? What about ARNI? What about the gliflozins? What is your experience or idea on that?
Yes, I mean, usually I think common heart failure drugs, like I really make a lot of effort up titrating the beta blocker optimally, the ASMR optimally. I'm a strong believer in spironolactone actually for the remodeling reasons. I have used I have added the ARNIs, but the problem is that those women are often young, they have a relatively low blood pressure, and they did not tolerate it well because it lowers the blood pressure more. So I don't think, in my experience, it adds a lot, but it adds to the side effect profile. So I really would first recommend, and they're very expensive. So I would recommend really using the other medication first properly.
Any experience on cardiac resynchronization therapy, CRT, in peripartum cardiomyopathy? What would be your
Yes.
And
Yes, I actually have. Yes, I have done a number myself and I had good experience. So I would really recommend that. So if you have patients who have fulfilled the criteria, I would definitely recommend it if the patient can afford it or if it's possible in your system.
Some more questions. So how do you differentiate peripartum cardiomyopathy from a heart failure that we get in preeclampsia and eclampsia?
Yes, that's sometimes difficult, but I mean, the patient with preeclampsia, eclampsia, they often present directly after delivery. I mean, our obstetrician on the call will be able to answer it better, but as you know, it's more a diastolic type of heart failure. It's due to the volume overload. It's immediately postpartum with very sudden presentation. And also, if you look, the sub-analysis of, there is a new paper coming out from this cohort, which actually really analyzed women with preeclampsia and hypertension versus the one who didn't have it. And you can see that the normalization of the systolic function is much quicker in women who have hypertension and preeclampsia. So sometimes you will only know it retrospectively, but women with hypertension preeclampsia usually don't have a dilated ventricle and they present more sudden and they recover more sudden. So that's the difference.
And in your data, I saw some of the patients who were having heart failure 1 month before delivery. Generally, by definition, it's in the last 1 month and the subsequent 5 months after delivery. So how would you include or explain that segment of patients who are identified to have heart failure prior to 1 month before delivery in your study that you presented?
Yes, it's virtually, most of them had a peripartum cardiomyopathy in a previous pregnancy. So they started already with a PPC, I mean, with a non-recovered ventricle, and then they developed symptoms, and then they were recruited actually by the investigators. And then the remaining one actually had hypertension and pregnancy and developed symptoms then a little bit earlier.
I think
Karen, considering that nearly 30% of deaths were sudden in onset, if a person can afford it, would you advise them using a wearable defibrillator for the first 6 months?
Yes, I think so. I mean, the German group from Hanover, I mean, they obviously have also more funding. They actually do that routinely now in the women with peripartum cardiomyopathy. I mean, in South Africa, we will not be able to do that. What we have done now, the data will also come out soon. We still need to recruit one more patient. We actually implanted loop recorders in patients with peripartum cardiomyopathy to see exactly what type of arrhythmia they are getting. So I haven't analyzed the data, but if you look under my name and in JAMA Cardiology from 2020, I think earlier this year, there is a publication on inserting loop recorders in women with structural heart disease. And we did find that you pick up a number of undetected atrial fibrillation, a number of SVT, and it changes the management. So one other option is to, it depends how costly it is, but I mean to have those for Medtronic, the very small links, and to insert it, especially in women with various forms of structural heart disease, because it avoids, you can reassure sometimes, like if you have a patient with hypertrophic cardiomyopathy, troponin T mutation, you can reassure a patient if you don't pick up arrhythmia, or you can treat whatever, atrial fibrillation, and avoid strokes. So this might be another option dealing with this problem.
So thank you, Karen, for your time. In fact, I was told that you need to leave by 8, in fact, 8:01, and 1,200 people across the globe have benefited by your talk. Thank you so much for your time. And now, dear listeners, we'll move on to the next presentation.
Thank you very much. Thank you for inviting me.
Thank you.
Thank you.
Thank you.
Thank you,
Bye.
Karen. Thank you. We enjoyed it. Thank you so much.
Thank you.
Now we'll have Dr. Shantanu. Dr. Shantanu Sengupta will present his presentation.
Thank you so much, Heart Failure Association of India. So actually, I wanted Karen to look at these slides, but anyways, so the we were talking about a lot about peripartum cardiomyopathy and heart in pregnancy. So I think it is important to understand the left ventricle in pregnancy. And this is a small case. This was a 31-year-old multigravida. She was previously healthy. This time admitted in labor pains and 37 weeks gestation, had a previous uncomplicated cesarean section. There was no family history of heart disease. And because there was a previous LSCS, she had to undergo a spinal anesthesia and delivered a healthy male baby. The intraoperative event was uneventful. Subsequently, post-operative, she after 1 hour, she said that she started feeling uncomfortable. There was chest discomfort and had breathlessness. She developed tachycardia, maintaining her blood pressure, had heart respiratory rate of around 32, and her SpO2 was around 85 with bilateral fine basal creps. So she was shifted to the CCU. These are the minimal changes on ECG. We immediately got the echo, and as you can see, the LV was dilated, and there was evidence of global hypokinesia. Couple of more images, very fast images were done. We got the labs. The pro-BNP was elevated. The drop I was slightly elevated, and she was given. This was heart failure, so it was diagnosed as peripartum evidence of heart failure. She was treated on a BiPAP, diuretics, and a lateral. She recovered. She started feeling better, and this is the echo. She had no symptoms, and 48 hours, the LV recovered completely. And as you can see, the dilatation was gone. Good ear ejection fraction. Couple of more images. We got her angiogram also, and it on the 10th day, and it was normal. So this is something very interesting, myocardial recovery in peripartum cardiomyopathy. And they have said that nearly half of the patients of PPCM normalize their cardiac function. And we were discussing this when we were talking to Dr. Sliva. But we reviewed the literature, and there was a report of Takotsubo syndrome in a pregnant woman. And the data came from Italy, and this patient had presented with cardiac arrest. So the interesting part was subsequently within a span of 3 months to 4 months, we had similar 2 more cases, and we published it in Indian Heart Journal that Takotsubo cardiomyopathy can occur in pregnancy, and it is associated with faster recovery of LV function, and should be always be considered in differential diagnosis of patients of heart failure in pregnancy. So this gave me curiosity in understanding what happens to the changes of the left ventricle in pregnancy, where we did a prospective data, a longitudinal prospective data, where we enrolled around 55 women, and they were all screened for all markers, including echo, at first trimester, second trimester, third trimester, and also at the time of labor. And this is the data. We know that there is weight, stroke volume, cardiac output increases. This has been published, but this goes in synonymous with previous data. But the interesting part was that longitudinal strain and circumferential strain start decreasing from the first trimester, and it progresses till labor, while the global radial strain increases during pregnancy. There is something regarding to the myocardial mechanics which we need to understand, which we have to see. And this is what I want to show is that normal strain is around minus 19, but there is a dip normally. So these were all normal pregnancy patients. Nobody had any cardiomyopathy on a peripartum. So normally the LV function goes down. And something which is very important, that strain can give you some insights about what happens in this group of patients who can deteriorate. And I think we need more data. And so pregnancy is a physiological condition with a lot of alteration in maternal loading and conditions, and there are a lot of changes in the hemodynamics which are associated with cardiac adaptation, and this helps in remodeling the LV. And there are few conditions where this can get deranged, lot of mechanics, and they can have peripartum cardiomyopathy. Interestingly, few patients do recover, and we need to follow this group of patients. Thank you.
Thank you, Dr. Shantanu, and thank you, Dr. Karen is still with us.
Oh, I can see her.
If permitted, can I send a question to you? So,
Right.
the peripartum cardiomyopathy can recover. How early can it recover? And the earliest recurring peripartum cardiomyopathy, whereas the latest recurring Takotsubo cardiomyopathy, how would you, tease it out?
Is that to me? Okay. I think I would also go with your diagnosis that it's probably a Takotsubo cardiomyopathy. I mean, if you do an angiogram, you will see it. Look, the angiogram would look different. I mean, the Takotsubo is you have more. It's a ballooning of the apex, and a PPCM is if it presents very acutely, you actually have not a dilated heart. I mean, the patients who present 1 or 2 days post-delivery massively very ill, they have an impaired systolic function, like a myopathy, but not a dilated cardiomyopathy, because it takes a little bit time to dilate. I did a study where I echoed patients every day, actually I never published it, but 20 patients with PPCM on a daily basis for 2 weeks. And it takes, when they present acutely, it presents time, and they don't recover that quickly. So I think I would think it's a Takotsubo cardiomyopathy.
Actually, I was looking at the strain images. I mean, you're right. They will have a ballooning kind of picture, but around 15 to 20% of patients can also come with global hypokinesia, and those patients can be very difficult to differentiate, and it takes 6 months for the strains to come back. So I think, but whatever you said makes sense, right? You're right.
Another thing that I would like to pose across to you is we know the phenomenon of afterload mismatch in accelerated hypertension. When the BP suddenly shoots up during pregnancy, during delivery, there is an afterload mismatch and there is LV systolic dysfunction, of course, without dilatation. These patients recover fast. So, I mean, the LV function recovers faster than it would otherwise happen in a peripartum cardiomyopathy. So, these cases are often mistaken as peripartum cardiomyopathy when, the early, I mean, we don't routinely do echo every day. In every we don't do every day. So, there is an echo done on the day of LV failure, day 1 or day 2 post-op, and there is LV systolic dysfunction patient, pulmonary edema patient improves, goes without a repeat echo, 6 months down the line comes for an echo, echo shows normal function. So now is it an afterload mismatch induced LV dysfunction, hypertension induced failure, or a peripartum cardiomyopathy? Where to place this patient? And sometimes we are in a quandary. Any thoughts on this?
I think it's sometimes there is no clear cut, and sometimes you will have patients who fall in between. I definitely don't recommend echo every day. I love research, so it's really just for my own knowledge. So don't even think I recommend that. It's just for me to understand it better. So, but I think you're totally right. I mean, I think one has to judge case by case. Most people you can distinguish, and some you will not know. Yeah.
And
Any
do
role of cardiac
routine
MRI?
on doing routine echocardiogram for all pregnant women, a screening echo for all pregnant women. We would like your expert opinion because many governments and agencies will like to get our inputs on this. Routine screening echo for all pregnant women.
Oh, I don't think that's affordable, but what we do, and you might find that interesting, you obstetrician amongst you, in our academic hospital, we now teach our obstetrician to learn basic echo, and they're very fast learners because you obviously you ultrasound for the baby. So you can, within a few days, you can learn a screening echo, and that is saving lives. I mean, to see if there is some calcification on the valve, it must be rheumatic. If you see a very poorly contracted left ventricle, that will guide you. If you see a fusion, we have a lot of TB, if you see an effusion. So screening echo by the obstetrician to be applied, and then you can make a decision who needs to be referred or not, is really life-saving in a country where I work, where we have so few cardiologists. But I don't think every woman can have an echo, at least not in South Africa.
Thank you so much, Karen. That is a very
Yes,
wonderful
Justin.
input. In fact,
Justin,
it gives
can I
us
have a question answered, Justin?
Yeah, just 1 minute. So, in fact, next week for all our investigators, we are we are planning a talk of 5 minutes on how to use the curvilinear probe of the obstetricians to get all the necessary echo inputs, including IVC size, pericardial effusion, LV function, RV function. Dr. Muthuprabha, please.
Yeah. I want to clarify at which period of gestation she wants to have a screening echo. A question to Dr. Karen.
We are not doing, what we do is, if you have a patient, we don't do screening echoes. But what happens if you have a patient coming to the obstetrician and the patient presents with shortness of breath? So, and especially if it's not in a teaching hospital, also our cardiologists, we are simply too busy and in the middle of a night to get the echo machine to the maternity hospital. So what we try to do is that if a patient comes, is pregnant, is short of breath, that the obstetrician is able to put the probe on the heart. And by simply seeing if the heart looks normal or if the heart has calcification or is weak, then at least you avoid unnecessary calling the cardiologist, which will help the overall service. And if you see, for instance, you can forget it. I mean, advanced pregnancy and mitral stenosis, how do you hear the diastolic murmur? I don't hear it. So if you see a calcified valve, you better call the cardiologist because you need to make a quick decision. I think it can really be very useful.
No, what I want her to clarify is, if at all we are going to do a routine screening echo for antenatal mothers, what will be the ideal gestational age to do that screening echo in an asymptomatic mother?
It probably is the second trimester. I mean, if you really would like to do that, I would recommend the second trimester, because then you can plan early enough before the patient decompensates.
Thank you.
Karen, in a cyanotic heart disease, because you deal with pregnancy and the heart disease, so in a cyanotic heart disease, what saturation will you use a saturation as a guide to allow them to continue pregnancy, or how do you go about it?
I take the whole picture. I mean, we have women who become pregnant and they are cyanotic from the beginning and have low saturations. But I mainly look at the right ventricle. So if the right ventricle has a good function, if the blood pressure is above 100 and the heart rate is reasonably okay, I think you can continue. I'm not so much looking at the saturation. I'm actually looking at the entire hemodynamic for this decision. But if you have someone in the week 16 and they have already a blood pressure which is only 75 and a heart rate of 110 and the poor RV function, they can't continue. It's not so much the SATs, it's more the rest.
Hari, is your question relevance primarily to reduce pulmonary blood flow, cyanotic congenital heart diseases?
Yeah.
Reduce pulmonary blood flow, cyanotic congenital heart diseases. I think Karen had made a very valid point. The point is, whenever the saturation goes down, it is more of a fetal loss than a maternal risk.
Yes, I think so. We published, if you look under my name, I think last year, a paper from a ROPAC study on 3,000 people with congenital heart disease, and more than 1,000 had uncorrected congenital heart disease. And we really I go quite in depth, in detail of the risk on each type of uncorrected congenital heart disease. I think it will be very useful for you, perhaps in India, where also like in South Africa, not everyone can have a heart operation. But most mothers do reasonably well. We were actually really surprised. The outcome was much better than the old literature. Yeah.
Yes,
Yeah.
Dr. Gupta.
Yeah. So I want to ask, what is your experience with doing a cardiac MR in this group of patients?
The
Do the
cardiac MRI?
Yeah, in the pericardial
Yeah,
cardiac.
oh, we do it actually regularly. In particular, because we do a dedicated heart disease and pregnancy clinic. So I have women who have sarcoidosis of the heart. I had a couple of those actually. And so if, for certain questions like inflammatory heart disease, and it's safe, and we had good results, or we had cooptations who are either were operated, but no one has ever seen them again. So you need to obviously look at the entire aorta. So we use it in selective cases.
But not routinely. But not routinely.
No, not routinely, not at all, no.
Any role of gene therapy in peripartum cardiomyopathy?
No, it's waiting for you. It hasn't been hasn't been done.
We are doing some genetic studies on peripartum cardiomyopathy. So, I mean, couple of genetic studies have come. I just browsed across, but there is a question from somebody whether any gene therapy in peripartum cardiomyopathy.
Yes, no, I'm not aware. Yes.
And there was another question, Eisenmenger and pregnancy. What has been your experience?
Yes, I can only also refer the paper in JACC heart failure. So Eisenmenger and pregnancy remains with the only group which really remains with a very poor outcome. Also pulmonary arterial hypertension and pregnancy, the mortality remains is almost 50%. So pulmonary hypertension is actually worse than Eisenmenger, but they have, it's mainly the thrombotic complication. And the fetal outcome is really terrible if you look. I mean, the chance of the fetus survival is also it's poor. It's less than 50%.
Yeah. I have a postulation which I'm planning to verify in my data. The postulation is all pulmonary hypertensions are not in the same basket. Like primary pulmonary hypertension, Eisenmenger, they may behave differently. The ASD with pulmonary hypertension, the large shunt, they may do better. So those kind of stuff. So you have any experience on, like, say, we have a TRPG, TR pressure gradient of 64 in atrial septal defect, and a TR pressure gradient of 64 in a primary pulmonary hypertension. I would definitely not disallow pregnancy in an ASD patient, whereas I will have hesitations in continuing the pregnancy in a patient with primary pulmonary hypertension or so.
Yeah, I fully agree with you. The patient with primary pulmonary arterial hypertension with a much worse prognosis. I mean, it's a different remodeling of the spiral arteries. I think you're totally right. It's not the same disease, actually. Yeah.
Yeah, I think we need some more information regarding whenever somebody comes with breathlessness, a pregnant patient breathlessness, can we predict the prognosis? Maybe some biomarkers, some EFC, some strain analysis. I think if we can have some prediction that this patient is going to behave poorly, their fetal outcome, I think we need, I mean, your thoughts, Karen. Yeah, that would be interesting.
Yes, no. I'm trying so hard because you're totally right. I mean, especially in a situation where not everyone can go to a tertiary center, you want to risk stratify, it's also expensive not to transfer the patient. We'll be looking at various biomarkers and combination of certain biomarkers. I mean, the NT-proBNP is there is a poster at the ESC, and my postdoc is just writing the paper. He's actually the first author. There's a poster at the ESC also from my team, and the NT-proBNP is actually a very strong predictor of poor outcome. And there is a cutoff point where the patients have a poor outcome. So that might, and it's not that expensive, and there is a bedside test for it. So that might be a tool to risk stratify who perhaps should come back sooner, who should be referred to a tertiary or combined clinic, or otherwise who can stay in the peripheral hospital. But that needs to be, it's based on our local data. That should be, perhaps you can do it in your trial. That should be validated in a bigger cohort, actually. Yeah.
Karen, we had done around 120 mitral stenosis, balloon mitral valvotomies during pregnancy. And what we have found is, you said the children are born underweight. We have followed up these children into 1 year, 2 year, or 3 year, and found that they catch up during their growth phase. So the initial, that is one observation which we have done. And these patients had a very good outcome. We didn't have any mortality in this 120 patients, even though we had 1 or 2 abortions.
Yeah, no, that confirms what I think. I think it's important to manage the mother well with the beta blocker, and the little bit of weight drop for the fetuses is not so bad. Yeah, but thank you. Thank you for sharing.
There is one question. Giving a little answer, I thought I'll get an input from you about anticoagulation in a lady with a mechanical prosthetic valve. Now, between 6 to 12 weeks, if the patient is on warfarin less than 5 milligrams or acinocumarol less than 2 milligrams, we give an option to the patient whether he would like to continue the same thing or he would like to switch over. But the patient says switch over. The issue is we are not supposed to use low molecular weight heparin unless we are monitoring factor 10A activity. Or we are supposed to give continuous infusion of unfractioned heparin and monitor APTT. Both are going to be very tough in a country or a state like this, where monitoring anti-10A activity is going to be costly, and admitting a patient for IV infusion therapy is difficult. I am working in a government hospital, so whenever I face this, I always admit them and give this infusion therapy. But then, what will be your advice as a via media in this scenario in managing 6 to 12 weeks in case we want to switch from oral anticoagulants? Because you're also, you're in though South Africa is very well advanced compared to many other African countries. What has been your advice or experience there?
Yeah, so what we do is, I mean, if someone needs less than under 5 milligram or up to 5, we actually continue with the warfarin, because we didn't have such good experience with low molecular weight heparin. I've seen a number of thrombosed valves. Also, our patients sometimes struggle to come back. You know, they have to come back weekly for factor 10A levels, and some have several children. They don't have someone who can look after the other children. So we have a lot of social circumstances where the mother actually can't come weekly for the levels. So I tend to rather continue with warfarin and switch in the end to heparin. However, if you have someone, we have the option of giving low molecular weight heparin. So if, for instance, if we have a mother who has no children, she has the 4th time a miscarriage, then we actually do this very intense monitoring and factor 10A and switching. And so we also adjust basically to the case scenario, but it's not without risk. And you know that the European guidelines differ from the American guidelines. The American guidelines are for low molecular weight heparin because of the litigation risk if the child is born with warfarin side effects, basically. And the European, they value the life of the mother more and don't want to have the clotted valves. So the guidelines are quite different if you take the US or Europe. And South Africa, we follow more the European guidelines.
So, Hari, you have any thoughts you would like to close? Or I think we have covered most of the questions. And Hari.
Justin, one question to you, Justin. Have you got any data on peripartum cardiomyopathy of Tamil Nadu, no? Or for MMC?
In MMC, we have 47 patients with peripartum cardiomyopathy between 2016, 17 and 18. And earlier we had presented about 2013 to 15, we have presented 18 cases in the World Congress of Cardiology at Australia. So I'm trying to pool these data and try to find out our outcome, combined outcome. So right now we have about our TNPHTR registry, we have about 18 peripartum cardiomyopathy registered. So pooling all together, we may get about 100 cases of peripartum cardiomyopathy. What exactly is the data that you wanted on peripartum cardiomyopathy?
Mortality in MMC. As far as MMC is concerned, out of the 47, what was your mortality rate?
Out of our 47, we had we lost 4 patients.
4.
Okay, Justin, shall we?
Please, please go ahead.
Okay, it was a wonderful session, and the discussion was much. Now I got the count that 1,300 people are watching the panel discussion currently. So it was a wonderful program, and we wanted to have the people with data from India. That is what we wanted to have, and we had the expert Dr. Karen Sliva. Thanks to her. She is the president of the World Heart Federation, and she is all the guidelines. She is either the first author or the last author, and thanks to her, and thanks to Justin, Dr. Muthuprabha, Dr. Chandanu, and our course director, Dr. Chopra. And I also thank Ankush from Lupin, and the Lupin who has sponsored the event by an unrestricted educational grant. Thank you everyone for watching, and we will continue this program every month. First week of every month. The next program will be on the advanced heart failure management, including cardiac transplantation. The date and the faculty we will inform you. Dr. Sandeep Seth from All India Institute will be coordinating the program. Thanks everyone, and good night.
Good night. Thank you.
We are off, Ankush.
So I'm ending the meeting now. Thank you,
Yeah.
sir.
Thank you.
Thank you, ma'am.
Thank you so much.
Thank you, Muthuprabha. Thank you for joining.
Thank you.
Thank
And
you.
Shantanu, thank you so much for your case.
Perfect. Thank
And
you.
Thanks.
Supraji, it was nice to be with you.
Now we are off, Ankush.